Welcome to Medicine Handy Point. Today we will do a brief discussion about plasma cell myeloma, which is previously known as multiple myeloma, and most of the material is from Cmdt book. So let's start. Now let's first define multiple myeloma. There are three way of presentation, so there will be three definitions. The first definition is the plasma cells in the bone marrow, any percentage, or plasma cell tumor, which is called plasmacytoma, presents with CRAB. Now, what is CRAB? So let's discuss that CRAB thing. CRAB is actually a calcium more than 11. So anyone having a calcium more than 11, creatinine more than 2, so anyone having creatinine more than 2, HB less than 10, and bone showing lytic lesion on CT scan, on MRI. So this is called CRAB. C is for calcium, R is for the renal, creatinine, A for anemia, and B for bone lytic lesion. So anyone presenting with plasma cell in bone marrow, any percentage, with the feature of CRAB, we should classify that as a multiple myeloma. Second presentation is the plasma cells in a bone marrow more than 60%. So if the bone marrow has more than 60% of plasma cell, we call that as multiple myeloma. Third presentation is if the serum kappa or lambda ratio is more than 100 or less than 0.01. So if it is more than 100 or less than 0.01, then it is called as multiple myeloma. Now there is a term called smoldering myeloma. What is this? It's a type of myeloma in which the plasma cell in bone marrow is between 10 to 59%. If it is more than 60%, we call it multiple myeloma. But if it is less than 60% or paraprotein level is more than 3 gram or more without an organ damage. So it's same as multiple myeloma, but there will be no end organ damage, while the percentage of plasma cell in bone marrow will be less than 60%, and paraprotein level will be raised, but there will be no end organ damage. What is MAGAS? MAGAS is monoclonal gammopathy of unknown significance. So it is actually if the paraprotein level is less than 3 gram in the serum, plasma cell in bone marrow is less than 10%. So if there is less than 10% of plasma cell and there is no end organ damage, then it is called MAGAS. Now, what is Waldenstrom macroglobulinemia? Now, how we define it? So let's define it. In this, the IgM paraproteinemia is present. When we do serum protein electrophoresis, there will be IgM spikes. Means the IgM immunoglobulin will be raised. Plasma cell in bone marrow will be more than 10%, but there will be no end organ damage, because end organ damage means multiple myeloma, so there will be no end organ damage. Now, how will we treat multiple myeloma? We always start with the triple therapy, which include immunomodulator agent such as lenalidomide. So lenalidomide is one drug. Then is a proteasome inhibitor such as bortezomib. So bortezomib is the second drug, and third, it is combined with dexamethasone. So these three drugs are always given in the beginning. Now there is new development, and it is in the form of daratumumab daratumumab. Daratumumab is actually anti-CD38, and it is combined with hyaluronidase phage. So hyaluronidase phage with daratumumab can be used in newly diagnosed, relapsed, or refractory multiple myeloma, or autologous stem cell transplant unsuitable candidates. So this new development has really changed everything, and we can use this in all these indications. Now, once the disease has been controlled, then autologous stem cell transplant is done following high dose of melphalan to consolidate the initial therapy given. So we use the melphalan in high dose, and then we do autologous stem cell transplant to consolidate the disease. Now, supportive therapy, which we can use in multiple myeloma, we use radiotherapy in a case of bone lytic lesions, bone pains. We treat hypercalcemia with pamidronate or zodendronic acid or rank inhibitor denosumab. The other thing, there is hyperuricemia, so we can use allopurinol and aggressive hydration. Free light chain can cause anuria by blocking the renal tubule, so it can be treated with plasma exchange. So this is the supportive therapy which we can give beside the initial therapy. Prognosis depend on stages. The stage one, what is stage one? It is actually beta 2 this is microglobulin, which is less than 3.5, and albumin is more than 3.5. So if beta 2 micro, this is not macro, this is actually micro. If the micro, there is I, this is not A, this is micro. If the microglobulin is less than 3.5 and albumin is more than 3.5, it is stage 1. Stage 3 is if beta 2 micro, this is again I, not A, microglobulin is more than 3.5 and albumin is less than 3.5, it is stage 3, while stage 2 is between 1 and 3. So stage 1 has a good survival and prognosis, while stage 3 has a poor survival and prognosis, while stage 2 is in between 1 and 3. I hope you like the video, and please subscribe to the channel.